All right, guys. Hello. Good morning, everybody. Good to see everyone. This last week, I came up with an idea, which I've now gotten approval from the Mexican Ministry of Health, that during World Cup soccer from June 11th to July 19th, we want to have a kind of and it coincides with Father's Day and with World Population Day. We're going to come up with some really clever campaign that connects teamwork, family planning, male responsibility with good sportsmanship and vasectomy. So we want to play football, soccer, all the whole thing wrapped into one campaign. We've already spoke to DKT. I spoke to the Ministry of Health. They're excited. We're going to try to get doctors in the U.S. and Canada on board. We're going to be hosting 48 countries in those during those 6 weeks of football or soccer, and we want to make sure that we make a presence and take advantage of all these people coming, especially at this time where there's so much conflict between the countries, much of it caused by us, I will say, but between us and the rest of the world, who knows if there'll be 48 countries. One of them is Iran. So what's going to happen in June and July is we don't know, but it's going to be a chance for us to make a statement about what we believe is a positive response. And so we'll figure it out. And anybody who wants to get involved, who's able to support, who wants to do vasectomy, we'll figure out something. We're working on it now. But I really appreciate just today, we're focusing on a different topic. I'm going to introduce Doug, who's going to be our MC today for this topic. And it was his idea as well, I think, or maybe it was, I'm not sure. But excited for everybody. So I pass it to you, Doug. Great to see everyone. And I'll be here listening as well.
Thank you, Jonathan. I'm going to try to share my screen here if that's okay. Can everybody see my slide?
Yes.
Okay. Well, first I want to do some thanks. I learned how to do this a little bit from Jonathan. First and foremost, Jonathan, for the vision, creativity, and never-ending drive to found World Vasectomy Day and to grow it into the largest male-oriented family planning organization in history. I'd also like to thank the organizers of this quarterly World Vasectomy Day webinar series. Kate Cordoba is World Vasectomy Day's Colombia-based Director of Logistics, and with Deidre, the energy behind the production of these webinars. I'd also like to thank the doctors who play a big role in choosing our webinar topics and in recruiting our speakers, Michelle Lebrec, Esgar Guarin, and John Curington. I've known our speakers for a long time, all board certified in family medicine, all dedicated to family planning since early in their careers, and in Esgar's case, lots of experience with obstetrics also. I'm trying to advance my slide here, and I thought the down arrow would do that. There we go. Maybe I have to hit enter or something. Sarah Miller has decades of experience providing primary care and family planning services in New York and Massachusetts, both in academic and in private settings. And Grace Shi has worked primarily in academic settings and, like Sarah, specializes in family medicine with an emphasis on complex family planning. Now, I first met Sarah when she visited me in Tampa for vasectomy training in 2011, 15 years ago. At the time, she was my 21st trainee, and boy, she was very good. She actually cheated a little bit by spending some time with Michelle Lebrec first, so no wonder she had such good technique. Anyway, it was 3 months after my second mission to the Philippines with No Scalpel Vasectomy International. During that mission, I was a little overwhelmed by the number of patients, and especially on the last day when Joe Alessa and I performed 107 vasectomies before our farewell dinner and our flight home. So I said to the founder and president of NSVI, I can't do this anymore. We need some help. And Ramon thought it would be a great idea to invite additional vasectomists in 2012. And the first one I thought of was Sarah Miller, followed by a few of my other trainees. Now, I hadn't met Grace, and I don't recall how the arrangements were made for Grace to join us, but there she was 14 years ago on that mission of 2012. Here, they're watching carefully to make sure I don't mess up our first patient, and soon they were working right alongside, sharing ideas and training some of the Filipino doctors. The patients were super appreciative, and you can see here Grace and Sarah looking all professional and satisfied. Later that night, they looked a little goofy, but by the next morning, they were giving lectures to the medical students and residents at Southwestern University Medical School. And you can see that their topic was female contraceptive options. And in fact, you can see that Sarah's slide there at the top says the patch makes you gain weight. I didn't know that, but I started to think more about how much women put up with in defending their eggs from invading sperm. If a couple wants a child, the risks of pregnancy are worth it. But if they don't, the risks are all borne by the female, as we'll learn from Esgar, which doesn't seem right. Having been grilled by numerous patients about the risks of vasectomy, I decided to reroute the conversation to the risks of not getting a vasectomy. So my daughter compiled a web page which was incorporated into our site, the risks associated with female contraceptives, with tubal ligation, with pregnancy, and with childbirth. Our current website explains risks as much as any, I suppose, but down at the bottom, you can see that there's a strong reminder there to consider the risks of not having a vasectomy. And I think this is something that we all should consider incorporating into our websites if we haven't already done so. And that's why it's important to pay attention today. I'm going to modify mine based on what I learned today. Now, Esgar has spent years delivering babies, and he knows all about the risks associated with pregnancy and childbirth. You probably know Esgar since as the guy responsible for the first mobile clinic in the United States. But I know Esgar since he came to me for training way back in 2013, and mainly because he felt it was time for men to step up to the plate. He returned for a refresher in 2016, and I could tell from Esgar's skill, drive, and his logical approach to everything that he would turn out to be an absolute vasectomy superstar, not only in his provision of vasectomy services, but as a current and future world leader of World Vasectomy Day. I said, Jonathan, you got to have Esgar come in 2017, and he has been just playing a leadership role ever since. What you can do to learn more about Esgar and kind of embrace his passion is watch the new video out on Esgar called Snip Trip, the Vasectomy Roadshow. Very inspiring. You can go to YouTube, or maybe Jonathan or Deidre can put the link directly up, but this is a video which you really shouldn't miss. So you can see how fortunate we are all to have this group of speakers, cumulatively decades of experience with the risks imposed on partners by men who do not have a vasectomy. Esgar is our first speaker, and I'm going to stop sharing my screen.
Doug is right. I used to do a lot of pregnancy care. I did an additional training after my residency in obstetrics, and I loved it. I absolutely love that. But that is exactly the reason my work in obstetrics would leave everything behind and just do only vasectomies. And it's because I recognized the risks associated with reproduction, the risks that female individuals who are capable of getting pregnant assume at the time of pregnancy. And as you mentioned, Doc, when you voluntarily want to get pregnant, you are assuming those risks. Even if you know those risks end up being worth it because of your intention of getting pregnant. But what if you don't have that intention? Or even more complicated, what if you're trying actively to not get pregnant, and you end up getting pregnant, and you didn't want to assume those risks. And that's what this talk is going to be about. What happens if you become pregnant, if you end up getting pregnant when you were trying not to do it, and what are the risks associated with that, in the association with not having a vasectomy. So we're going to do this. We're going to talk about 4 different types of risks. We're going to identify who the patient is who normally gets a vasectomy. And we're going to identify who the partner usually is of those individuals who get a vasectomy. And we're going to end up with a very brief clinical case from an actual patient of mine who I had. About almost going into 7 years ago, I stopped doing obstetrics, but my passion for vasectomies and the reason for me to do the vasectomies associated with my practice of obstetrics continues to be there. I don't take care of deliveries anymore. I don't do C-sections anymore, but I am doing the vasectomies also because I continue to work with those individuals who could potentially get pregnant precisely to avoid these risks. So let's talk about a vasectomy. Well, we all know is the only method of permanent contraception for male individuals. Is the 5th most commonly used method of contraception. And unfortunately, at least in the United States, is 3 times less common than tubal ligation. If we look at data, and I'm not going to share that with you now, but if we look at data, worldwide data, the discrepancy is even bigger. The gap is even bigger. When we talk about the number of tubal ligations done compared to the number of vasectomies, the ratio is 20-1. For every vasectomy, for every woman for every female individual who depends on a vasectomy as her method of permanent contraception, 20 women rely on tubal ligations. And that is worldwide. There are countries where we don't even have data because the participation of male individuals with vasectomies is so low. It is so low. So there's a huge gap that we want to close because of the potential risk associated with the pregnancy and the other interventions. But we're not going to talk about the risks of tubal ligation. We're going to talk about the risks of pregnancy. So in the United States, and this applies to other places around the world, according to the National Survey of Family Growth from a recent study, this table shows the usual suspect or the usual patient who gets a vasectomy. Those are patients between 35 and 49. You see 10 close to 11% of men between 35 and 39 years of age use a vasectomy, have gotten a vasectomy. 40 to 44 is 13%, and 45 to 49, 14.5%. This is a very important issue that I want you to grasp now that we're starting this conversation, because that's going to lead us to understand why it is important to consider and why not having a vasectomy is a potential risk. So let's talk about pregnancy. Pregnancy is a wonderful thing for those individuals who have chosen to continue with the pregnancy, for those individuals who have intended to be pregnant. But it doesn't come without any risks. You know, in general, pregnancy carries risks, and maternal morbidity and mortality. There are lots of figures demonstrating those facts. According to World Health Organization, approximately 260,000 women died during or following pregnancy in 2023, and the global maternal mortality ratio is about 190. In 2023 was about 197 deaths per 1,000 live births, down almost a third of the decrease from 2000, which is a great thing, but still is high. It's still, we have people dying, people capable of getting pregnant dying or getting deadly sick because of a pregnancy. In the United States alone, and I know this is a conversation, a worldwide conversation, but this is giving you data about the United States shows you that if we have issues in the global north, in the global south, things are not going to be any better. Approximately 18.6 deaths per 100,000 live births have happened in the United States in 2023. And severe maternal morbidity, that is life-threatening complications during pregnancy and childbirth, are estimated to be 6.2 per 1,000 deliveries. This is the United States. And again, this table shows you data US, but it's very helpful anyways. So maternal mortality rate by age, when you look at that age, look at what happens. You know, in 2022 and 2023, there is a decrease of that, but still very, very high compared to the other ages when you look at patients between 40 that are 40 years old or older. So that's very important to consider. So pregnancy comes with risks. right? But what are the causes of that maternal mortality and morbidity and mortality? Well, according to WHO, 75% of the maternal deaths are due to these conditions: bleeding, infections, high blood pressure, that is specifically complications from the actual delivery, and unsafe abortion, which should be included in this. Only hypertensive disorders account for 10% of the pregnancy complications worldwide. And there are other things that also have related to the pregnancy. Stillbirth is an issue. About almost 2 million stillbirths happen in 2021. That is approximately 1 in 72 births, most occurring in low and middle income countries, according to WHO. And there are also the placental complications, placenta previa, for example, which is, as we know, increasingly more frequent. That is an abnormal placentation, abnormal attachment of the placenta to the uterine wall, if the patient has prior cesarean sections. That poses serious maternal risk. So we talked about the risks of pregnancy in general, but how about the risk associated with how the patient delivers? Well, we do know that there are risks associated with that. And we know that cesarean section carries a higher maternal mortality and morbidity compared to vaginal delivery. That's a known fact. It's a major surgery. We're talking about an organ that at a certain point could be carrying almost 30% of the total blood volume, and we're inciting that during the cesarean delivery. So that increases the risk. In low resource settings, women who deliver by C-section are 5 times more likely to die than those who deliver vaginally because of the environment, because of the availability of resources to manage complications. Infection and thrombosis are obviously high risk because this is a major surgery. The mobility after the cesarean section might be limited, and therefore these risks increase. Infection rates are obviously increased. Infection rates are approximately 10% for vaginal births and 25% for cesarean section. Severe postpartum pain is going to be higher, up to 40% with cesarean section, with chronic pelvic pain higher with cesarean sections compared to vaginal delivery. So these are risks associated to the mode of delivery. Maternal death with C-section by this study in the Netherlands showed that it's 21.9 per 100,000 maternal deaths versus 3.8 per 100,000 costs. I mean, not just the risk associated with the patient herself, but also the cost. Vaginal births are cheaper, have shorter hospital stay, and compared to cesarean sections in low risk. So we talked about the risks of the pregnancy. We talked about the risks of the mode of delivery. Let's talk about the intent of pregnancy. So this study from Nelson, published in JAMA in 2022, did a systematic review and meta-analysis of 36 studies with over 500,000 participants. It was 14 core studies, some cross-sectional studies, and it looked at 20 plus years of this data and compare unintended pregnancy with intended pregnancy. And this is what they found. Unintended pregnancy was significantly associated with higher odds of depression during and after the pregnancy. Look at the data there. 83% versus for depression during pregnancy. And this is not taking into account the support network. Postpartum depression is almost twice as higher. The odds are twice as higher with patients who had unintended pregnancy. Interpersonal violence is 3 times higher if you have an unintended pregnancy. Preterm birth increases as well, and infant low birth weight. So if you did not intend to get pregnant, these are actual risks that the patient is facing. How about now? So we talked about the pregnancy risk. We talked about the risks of the mode of delivery. We talked about the risk associated with the intent of pregnancy. And now let's talk a little bit about who those partners of the patients who get a vasectomy are. So according to the Pregnancy Risk Assessment Monitoring System, and this is in the United States, they did this study, and it was published in 2018, where they looked at over 35,000 married women in 15 states and New York City. And they looked at them up to 4 months postpartum. They found that about 3% of the sample reported that their partner had a vasectomy, and that was their postpartum contraceptive method. right? From those, typically those patients, those female individuals whose partners had a vasectomy for postpartum contraceptive method, those patients were typically in their 30s, often averaging around 37 years old. 29% of those patients, that is a third, were 34 years of age or older when their partner had the procedure. That is important to know because we're gonna talk about those individuals with the next slide. But nearly 60% of married postpartum women whose partner had a vasectomy reporting not using secondary contraception following the most recent live birth. So there's a huge gap of an unmet need for contraception there. So these are the type of patients who get a vasectomy, which means the majority of these patients, a big chunk of these patients are 34, 35 and older. And now the question is, what happens with those patients who are 35 and older? There's a term that we use for those patients, and it's called advanced maternal age. And the reason why we make that clarity is because those patients have increased risks associated with the pregnancy itself because of the age of the patient. So we need to think that many men seek vasectomy between ages 35 and 45. Therefore, by proxy, we can assume that their partners are often at advanced maternal age. And therefore, delaying permanent contraception would expose partners to significant pregnancy-related risks, not just the risk of pregnancy, but the risks of pregnancy after 35. So what are those risks, right? So again, the definition is there, 35 or older at the time of delivery, that's advanced maternal age. The risks increase gradually, well, not abruptly. It's not that the patient turned 35 and all of a sudden all the risks increase. But what are those risks? One of them is the risk of Down syndrome, and you see the rates there, right? That is associated not with the patient, but with the child that they're carrying. What else? Maternal mortality and age. This study from Jacobson in Sweden in 2004 showed that the maternal mortality increases considerably. Patients who are between 20 and 29, 1.4 deaths per 100,000, and look how sharply it increases by 40 to 44. Above 45, the risk is much higher. There are older birth complications. The study from the UK showed that older age was linked with higher rates of complications. The only thing that is good with pregnancies after 35 is that breastfeeding rates are higher. But other than that, it's just increases the risk. Now, as Doug said at the beginning, there are some individuals who delay pregnancy for a later time in their lives, and that is completely appropriate. If they are intending to get pregnant, if they have the intention of getting pregnant, they're assuming there's risks, and that is acceptable because knowingly they're getting there. But if somebody has satisfied their fertility and they get a pregnancy that was unintended, these are the risks that they were not signing up for. So far, we talked about the risks of pregnancy in general, the risks associated with the pregnancy based on the mode of delivery. Then we've talked about the risks of the pregnancy based on the intention of getting pregnant. And we talked about the risks associated with the pregnancy based on the maternal age. With all that, let's just sum it up with this case. And this is an actual patient of mine that I had many years ago. That this is one of those cases that made me think that I didn't want to continue to do obstetrics, not because that I hated it, but because I felt I was going to be much more effective in my work by focusing on vasectomy, simplifying the access of vasectomy, and providing high quality, compassionate services of vasectomy. So this patient, we're going to call her Jane, of course. She was a 37-year-old female, G4P3, being pregnant 4 times. This is her 4th pregnancy. She was pregnant 39 weeks. She did not intend to get pregnant. She was actually using Depo-Provera. She was using an injectable deposit medroxyprogesterone for contraception, but she ended up getting pregnant. She had an uncomplicated pregnancy. That was a plus. She was already advanced maternal age. Everything had been fine with her. She did not develop preeclampsia, no gestational diabetes, none of those things. But the issue was that she had 3 previous cesarean sections. She had a first cesarean section because of failure to progress. So she did not dilate fully, and she ended up having a cesarean section. And she had the second and the third one The second and third pregnancy were cesarean sections. So she had, she had 3 cesarean sections. I did not do those. So when she came to me, this was her 4th pregnancy. So obviously, we're not going to do a VBAC, at least not in my environment. The risk of uterine rupture, which is the risk associated with an attempt vaginal birth after a cesarean section, with this many cesarean sections, is too high. Nobody's going to give her a vaginal delivery. So we admitted her for a repeat cesarean section. She wanted to have permanent contraception. In fact, she didn't want to be pregnant before. She was doing the right thing by getting her shot. But it turns out the hospital I was practicing at was a Catholic institution. So based on their ethical religious directives, I could not provide any method of contraception while in the hospital. Many times I actually had to wheel patients out of the hospital to my clinic, which was next to the hospital in the same building, but not in the premises of the hospital itself. And we were independent, give them a shot of the Provera before discharging them from the hospital and bring them back into the hospital, because the hospital would not allow me to do that. So the idea of having a tubal ligation in the middle of her C-section was it was not going to happen. In fact, I tried, and I had to send a letter to the bishop of the diocese, the organization surrounding that area of the hospital, where the Catholic bishop would have to give me permission to do that. And guess the answer? The answer was no, because of their ethical religious directives. So she couldn't deliver at the different institution. And the problem here was her husband didn't want to get a vasectomy. I talked to them, and he insisted that he would not do that. So this woman was being exposed to having a cesarean section and then having to go at the 6 weeks after 6 weeks postpartum to another institution to get her tubal ligation. And that, in fact, was what happened. So I'm going to show you this table for us to close this. These are the complications she was being exposed to. She did have an increased risk when on the first line, an increased risk of placenta accreta issues. That is the risk of an abnormal placentation, that the placenta was going to be attached too tightly and probably difficult to remove, with the risk of postpartum hemorrhage and the risk of a hysterectomy in the middle of a C-section, which will be much more complicated because of the multiple cesarean sections she had. There's an increased risk of placenta previa, that is the placenta being down close to the cervix. She was not going to have a vaginal delivery. She was going to have a cesarean section, but that increases the risk of postpartum hemorrhage. The risk of adhesions, because she has had multiple intra-abdominal surgeries. She might not see the problem right away, but when she's in her 60s, early 70s, she might end up with a bowel obstruction because of the adhesions. The risk of intraoperative organ injury increases because of those adhesions as well. The risk of postpartum hemorrhage increases. The risk of blood transfusion. The risk of hysterectomy might seem like it's low, but when you look at that, it's actually 6-7 times higher. And the risk of ICU admission. And look at the risk of maternal mortality. 21.9% per 100,000 for C-section versus 3.8 per 100 of vaginal delivery. So this female individual pregnant, who did not intend to be pregnant, who was doing, I think, to avoid the pregnancy, got exposed to all these risks. At the end, she defined. But was it fair for her to go through all those risks when a lot of that could have been saved, could have been avoided by having a timely vasectomy? That is the question. Thank you so much.
Thank you, Oscar. So we're going to continue sort of down this clinical scenario and think about what the other options are if you have an unintended pregnancy. So perhaps you have decided you don't want to have any more biological children with your partner. We've talked about the risks of pregnancy, and now we're going to move to other potential consequences, which would be abortion and miscarriage. Next slide. So the first thing I wanted to share is that safe abortion is quite low risk. However, not all abortions are safe abortions. Click. So the World Health Organization actually has quite specific definition of what is a safe abortion. They have to be either a specific method, so medication abortion, or several types of procedural abortion. It has to be done by a qualified provider. In order for it to be considered safe, both criteria have to be met. 45% of abortions, though, globally are unsafe, meaning one of those two criteria are not met. So sometimes it is by the method type. So I've listed some of the types of methods that you can see folks trying to terminate pregnancy with, or it can be by an untrained provider. To just give you some like numbers for that, 45% of unsafe abortions means about 50,000 women die each year globally from unsafe abortions. And also, not surprisingly, the percentage of unsafe abortion is much lower in higher resource country and around 12%. And then in low resource country, it can be up to about 50%. And of course, the proportion of abortions that are unsafe increases as abortion laws become more restrictive. So here's a map of the world, and you can actually see how restrictive abortion laws are in each country. The least restrictive is in very light green, and then in orange is where abortion is permitted to save a person's life, and then dark brown is where abortion is prohibited altogether. I invite you all to, man, sorry, I lost my chat window here. I will paste in the chat later. So you all can look at your specific countries, because I know we have an international audience here, to see what your, oh, here's my chat window. There's the link if you want to look in the map there. So I'm going to shift now to focus specifically on safe methods of abortion, because quite frankly, unsafe abortion is very hard to track what kind of methods people are using, what it looks like around the world. We do know that obviously it is much less safe. So when you look at safe abortion methods, like I mentioned, there's medication abortion and then there's procedural abortion. In the realm of medication abortion, there are two main medications that are used for medication abortion. The first one is mifepristone, and it is a progesterone antagonist that stops pregnancy growth. And then misoprostol is a synthetic prostaglandin that helps soften the cervix and help expel the pregnancy. So this is a chart from the World Health Organization around the medication abortion regimens that can be used at different gestational ages. And so as you can see, in most of these, there's a first tablet of mifepristone followed by tablets of misoprostol, often given in series to help expel the pregnancy. In terms of procedural abortion, so now procedural abortion is something like I'm a family physician, and for first trimester abortion, so abortions less than 14 weeks, those are very commonly done in just a regular outpatient clinic. So in my family medicine clinic, this is something I can do. So another word for this is uterine aspiration, and I took a screenshot really of the equipment just so those of you who don't do gynecological procedures can have some idea of what is necessary. It's not a lot of extra equipment for a first trimester uterine aspiration. So on the left, the sort of slightly curved S-shaped metal instruments are called dilators, and those are what is used to gently open the cervix to help access the uterine cavity. The plastic straw-looking thing is we call a cannula, and that is the cannula is what we use to suction out the pregnancy. And then we have pretty standard gynecological instruments like the speculum, a ring forceps, and a tenaculum. So these are very common tools used in procedural abortion. For the other type of procedural abortion, which is called a D&E or dilation and evacuation, the instruments are actually quite similar, although there are larger forceps. This procedure tends to be done in second trimester or above gestational ages, and then are done with ultrasound guidance. So this is a reason that it's a little bit lower access for folks because more specialized equipment is necessary, and often more anesthesia is necessary. So you need more skilled providers. I wanted to show you all sort of just a basic diagram of how you can see the aspirator is used. So the plastic thing that the provider is holding is the vacuum. So you can use that to create a small suction vacuum and attach it to the straw cannula that I showed earlier. And that is what is used to suction out the pregnancy. So since we are here to talk and think about risk, what are the risks of both safe abortion and unsafe abortion? And I just put them here in a very simple chart for you to see. So safe abortion is quite safe. So less than 1% risk of any type of major complication, including hospitalization, surgery, transfusion. Other risks such as medication or procedural, medication infection rate and procedural infection rates are quite low, so less than 0.5%. And the mortality rate is very low at less than 1 per 100,000 procedures. And if you can remember some of those numbers that Eskar was just showing us, this is much safer than even pregnancy. And actually, if you think about the risk of a safe abortion, it is even lower risk than an allergy to penicillin. In contrast, when you think about unsafe abortion, it's much higher risk. So obviously, depending on the type of method used, you can have 10 to 20% risk of infection, trauma, hemorrhage, and 15% of maternal deaths, about 68,000 per year, are from unsafe abortion. So that's a bird's eye view of, actually, the other piece I wanted to show that is not reflected on the medication or the risk slide is really the other burdens of abortion. So I do want to mention sort of social and financial burden. So in the United States, an abortion out of pocket is between $500 and $1,000, plus the cost of travel, childcare, and lost wages. And in the United States, federal legal access to abortion is no longer supported. And when that happened through the Dobbs decision, the mean travel time to get to an abortion went from 3 hours to 11 hours. And the need for overnight stays went from 5% to 60%. So there's a huge just financial logistical burden. And then getting an abortion is extremely socially complex to get all of those things together. And often the complexity of getting a procedure pushes folks beyond their legal or accessible abortion limits, and then they cannot get an abortion. So I want to turn attention now to miscarriage, which of course is another possible outcome for an unintended pregnancy. And it is very common. About 15% of recognized pregnancies end in miscarriage, mostly from chromosomal abnormalities. And in terms of clinical management of miscarriage, there are 3 main ones: medication, procedural, and expectant. They're largely the same as what I just talked about in terms of using the mifepristone, misoprostol, or doing a uterine aspiration. So I will not repeat those things, but I do want to give to some other context for thinking about risk or the impact of miscarriage. And a lot of it is from the process itself of miscarriage. So I put a couple of quotes from folks who have had miscarriage, from folks who take care of people who experience miscarriage as well. And I'm just going to read this quote from Michelle Obama, who experienced miscarriage. And she said, "I felt lost and alone, and I felt like I had failed because I didn't know how common miscarriages were because we do not talk about it. We sit in our own pain thinking that somehow we're broken." Oops, I missed one more quote there. The other thing I wanted to touch on is criminalization of pregnancy in the United States. And I'm not specifically talking about abortion or miscarriage here. I'm talking about pregnancy in general. And I focus on the US because that is where I'm here. And there is a lot of risk here for just being pregnant. So in the United States, and this data is probably doesn't include cases from within the last year, but there have been 412 documented cases of pregnancy criminalization. So this is not about abortion because almost 300 of those resulted in a live birth. And I'm going to let you read the other stats on pregnancy criminalization in the US and instead and share just a little bit of a story of a person who was in South Carolina who was criminalized for her miscarriage. Her name was Amari Marsh, and she had a miscarriage at home and was bleeding. Her boyfriend then called 911 and she went to the hospital. At the hospital, she was interrogated by the police and charged with murder. And she spent a month in jail and was charged with 20 years in prison. She was ultimately on house arrest for an entire year before she was acquitted. So when we think about outcomes of unintended pregnancy, including the health complications and legal consequences, you can understand why people look to contraception to bridge them during this decision period. And we were kind of conceptualizing this as if you think of if you do vasectomies, I often ask my patients like, "Oh, how long have you been thinking about a vasectomy?" And the answer I often get is like a year or a couple of years. And so, what is happening in this couple of years that people have decided to have a vasectomy but haven't gotten them? And so now we've talked about pregnancy as an outcome, we've talked about abortion and miscarriage as an outcome. And then Sarah's going to talk about when folks use contraception as that bridge, what that looks like.
I'm so happy to be here with you all. When we talk about contraception, I'm talking about this in the context of risks of not having a vasectomy. So continuing contraception that is less desirable is where I'm going to focus. This is a picture of a bunch of different real-life IUDs or intrauterine contraceptives. IUDs are generally considered very safe and work great, but and their use is going up globally, but many people don't like the idea of them or can't afford them or don't live in a place where they have access to them. There's been a lot of social media attention to the fact that for some people inserting IUDs is very extremely painful. And then there's people who really like the idea of being in control of their contraception and not having contraception done for them or implanted with them. And that has to do with both personal preferences, but also the fact that our world has a very long history and suffers the after effects of reproductive coercion and people having experimented and not given choices of the use of contraception. And in fact, certain people are still being denied removal of contraceptives that need to be removed by healthcare providers. And also of note, highly effective methods like intrauterine contraceptives are only highly prevalent in a handful of countries around the world. This is Bertha and Casey. They're much like Esgar's couple. They're also based on people I've known. Bertha has had 3 pregnancies and she's coming in postpartum from after her third because she has pain at her C-section scar and needs to get her hemoglobin rechecked because she needed a blood transfusion with the delivery and she wants to discuss birth control. Their first pregnancy was planned. The second one happened while Bertha was taking birth control pills. She had not missed her. She'd been able to get all of her refills and was very, very good about taking the pill every day. And then the third pregnancy happened very quickly after the second delivery. Her IUD had fallen out that was put in postpartum, and she didn't even know that it had fallen out. She has tried a contraceptive implant in the past, but felt that it made her hair fall out. And then she has heavy periods and migraine headaches, and it's important for her, for a sense of being a woman, to have regular periods. So like what's important there is that Bertha has been through a lot, both in terms of pregnancies and deliveries and in terms of contraceptive use. So some things to think about is women are already bearing the burden of pregnancy, childbirth, and a disproportionate amount of childcare. Why are they also having to bear the burden of contraception? Is it Bertha's responsibility to do this? So when we see this case, and I present this case to enthusiastic family physician and family planning providers, they're always trying to come up with how to talk to Bertha about her options and what she could use. And even when we're talking about this in the context of vasectomies, a lot of people don't think about vasectomy when we look at Bertha and Casey. What are the costs to Bertha of contraception? And then I'm going to talk later about shared risk as a concept, which is really important with this. So when we think about, I'm not going to go into detail about all the different types of contraceptives that are available, except to say that there are many available for people with uteruses, and there's different ways to think about them. So one way to think about them is how well they work. Another way to think about them is how frequently you need to use them or how long they will last for. You can also think about whether or not they have hormones and offer hormones to the person who uses them and which type of hormones, and whether or not it's permanent. There's some really great websites and places that help people help people who are deciding about contraception for themselves and providers go through these different methods. One is bedsider.org. If people don't know about this, it's wonderful. It's great. It's got a lot of pictures, so it's not really based on words or high literacy levels. And you can filter contraceptive options based on patients' values, preferences, and needs. For example, you can filter it based on effectiveness, but also side effects that people either want or want to avoid, whether it protects from infections, whether or not it affects periods in any way, and based on whether people want to have hormones or not. You can next slide. Okay, so when we talk about efficacy, because it's something that is very important to us as physicians and professionals and people with higher education, we're very good planners, and we really think that pregnancy needs to be intended and planned. Okay, so for us, and timing and planning and like efficacy seems to be the most important thing. But that's not actually the case for all patients and all people, like we talked about before. But if we're talking about efficacy and thinking about it in context, one of the things to know is, what does this mean? So when we look at different birth control methods, we could look at perfect use, which means that what the lowest expected failure rates based on like clinical trials, and typical use. Typical use is failure rate based on real personal use. So not like people who aren't responsible, but actually real people and how they use them. So if you look at and failure rate means for people who rely on this method for a year, what are their chances of getting pregnant? So this is helpful for patients and for us. The picture on the right side of the screen, that if you're the less failure rate is of 100 people in a year, one woman who use it, one woman will get pregnant. Okay, so of note, methods that rely on repetitive use or user use or getting refills have a lower typical use rate compared to the perfect use rate, whereas things that are permanent or provider insert and not user dependent have a typical use rate more in line with perfect use. Next slide. So when we think about contraceptive safety, how safe contraception is, it's important to know that certain medical conditions can make different types of birth control either relatively or absolutely contraindicated. And the World Health Organization and various countries' own counterparts have put together guidelines that people can use to reference various medical conditions and whether or not that means that specific contraceptives are put a patient at risk for them. And there are apps that you can use that are here and we can share with you as well if you want to be looking up particular medical conditions and what they mean. What's important to also note is that people with medical conditions are less likely in studies and to have access to reliable contraception. And pregnancy risk is also greater for people with the medical conditions that contraception puts them at risk for. So if something it is, I'm just going to say this over and over again, there is no risk of contraception that is higher than risk of pregnancy. Okay, next slide. And so when we look at if you're going to be using these references from the MBC or medical eligibility criteria, it's important to know what the safety levels mean. So a 1 safety level, which is green, means go, means that with that medical condition, there is no restrictions for the use of contraception based on whatever the condition is. Level 4 means generally the risk of using that birth control is unacceptable in the setting of that condition. And then the 2s and 3s mean think about some risk that may or may not be balanced against the risk of not using the contraceptive. And the next slide shows a screenshot of one of the resources for looking up based on people's conditions. So we have age, anemia, bariatric surgery, various things on the left, and the different contraceptive methods listed in the columns on the right. But the main thing to note is look at all the greens. So most birth control is extremely safe with no restrictions for most people, even with medical conditions or age or that type of thing. Okay, so what about estrogen? Let's see if this stuff comes up when you press the next thing. Okay, so we hear a lot about people's concerns about being on hormones, specifically estrogen. And what are the contraindications? What medical conditions make it so thinking about estrogen containing methods might be something we want to think about, pause about. So migraine with aura, uncontrolled hypertension, which means a systolic blood pressure above 160 or a diastolic above 100, current blood clotting disorders, being postpartum, recently postpartum is an absolute contraindication for estrogen, and tobacco use. Now, tobacco use is based like someone who's under age 35. It's not an absolute contraindication. That's a level 2 risk. But for someone who's over 35 and smokes more than 15 cigarettes a day, that is considered a high risk, and you should consider not using estrogen or the risks of estrogen in that patient. On the flip side, which is the other part of this slide, I also want to mention that for people who are worried about estrogen and using hormones, there's actually numerous benefits to women of using estrogen on a regular basis. There's lots of different menstrual disorders that can be controlled or fixed by the use of estrogen. It decreases the chances of certain types of cancers, endometrial and ovarian specifically, which of note are types of cancers that we don't have great screening methods for. It's shown to decrease pelvic inflammatory disease. It can be useful for people who have hormonal imbalance like polycystic ovarian disease, and is used to treat acne and excessive hair growth. And because estrogen containing methods often decrease ovulation, they also can decrease the incidence and sequela of ovarian cysts. So this is just something to note, even for people, like many people want surgical methods or vasectomies because they desire to avoid hormonal contraception, which is fine whether they have contraindications or not. But some people, even if someone has had a vasectomy, their partners may wish to continue hormonal methods in order to treat some of these other conditions. That being said, going back to the efficacy chart, a vasectomy is much more effective than these methods. Next slide. Okay. Also, what I didn't mention before when we were talking about the efficacy slide is I just want to make it clear that even with perfect use, even with somebody who's using birth control, even the perfect use highly methods have failure rates, which means like pregnancies will occur for people who are taking birth control, even if they're taking it well. Okay, so I think it's important for us to all have a concept of the idea of shared risk in the idea of couples making decisions about contraception. So shared risk can be defined as a sum of risks to all the members of a sexual couple with use of contraception by anyone in it. And that's especially compared to the risk of pregnancy to the couple. And that's one thing to think about, is how do we balance doing no harm with seeking the greatest good or benefit when male contraception has impacts beyond just the male user. Female contraceptives are easily justified because their own risk is being reduced of pregnancy in order to use them. But if you think about, like, I've often said for couples that come in that, like, even for the man of a male-female couple, even for the man, like him having an office-based vasectomy is probably easier for him than his partner having a tubal ligation. Even him going through it, not just because of her needing to get there and recuperate and the time it takes for her to be away from the family, not being able to participate in household duties and that type of thing. So if you think about shared risk, then the risk of not having a vasectomy for the male partner is more than just a financial burden or having to take responsibility for a child or an additional child. Okay, I wanted to just talk a little bit about, Esgar touched on this, about access to contraception. Globally, access to contraception, especially highly effective methods, is becoming more of an issue. So there's already been a very high unmet need in the world. When we look at people who need family planning, meaning they desire to either delay or avoid pregnancy, there's over 1 billion women and girls who need contraception, and 190 million don't have it, use any. So this is considered an unmet need. Because of foreign aid cuts from the US, there is a growing number of people that have been directly affected in the last year and a half by not having access and being turned away from contraceptive methods and programs that they've already used. And this will result in increased tens of thousands of increased pregnancy-related deaths globally, directly as a direct result of the lack of access that was there and is getting less. So, and even if access and cost, access is not an issue in places where women have ready access to affordable birth control, there still are some costs and co-payments, unwanted side effects such as risks of blood clots and strokes, libido changes, the time it takes to get to the doctor, pick up refills, and having to remember to do all of this. And sorry, just to go back, Doug, when you showed the slide of us saying that the patch causes weight gain. The funny thing about that is that was actually a myth that was listed, that when we asked people, is this true or false? And the answer is actually false. But taking a hormonal contraception, just to go back, does not cause weight gain. Eating makes you fat. Birth control doesn't make you fat. That's what one of my favorite nurses said to me. But yeah, just to go back. But again, it's not our job to dispel all myths, and we can't do that. So we have to meet people where we're at for all of this. Okay, next slide, please. Okay, so Bertha and Casey, like, they're done. They can't be pregnant. They've made it clear that having the most effective method is the most important to them, and they want permanent contraception and they want surgery. Okay, so who gets the surgery? Bertha or Casey? So globally, Esker, I just saw this I looked this up in the UN recently. The ratio, you said 20-1. The ratio I saw was that there are over 10 tubal ligations globally for every vasectomy. So Casey is 10 times more Bertha is 10 times more likely to get a tubal ligation than Casey is. And that's gone up. The disproportion of women needing to do it more than men has gone up since 1994, has more than doubled since 1994. It's maybe even quadrupled if you look at where Esker found his statistics. And that's despite the fact that head-to-head vasectomy is there's like no comparison. If it's two people in a couple, the risks and costs are greater for Bertha than they are for Casey. So they've been through a lot. So this all just makes us think about what the risks are of Casey not having a vasectomy in this context.
Just thanks to everybody that attended. And if anybody needs CME credits, please get in touch, because you can get them for this very informative, very important, very necessary way of looking at the risks. So
We entertain any questions,
Yeah.
Deidre? Oh, I have one. Would that be okay?
Sure,
And
of
this is for Grace, because we get an increasing number of these. Let's talk about Bill and Barbara. And Bill's 53 and Barbara's 50. And Barbara's been on birth control pills for quite some time, and she still cycles regularly. But she heard something like Esgar's talk about how dangerous pregnancy is in advanced maternal age. And she really doesn't want to get pregnant, so she doesn't want to stop those birth control pills. And she's still cycling, but she thinks it's not quite right to be on the birth control pills. So how do we handle that? What would be your advice? Now you could say, well, stop the birth control pills and Bill can go on to condoms, but he's starting to develop a little impotence problem and he doesn't think that he's going to do well with condoms. So, and she, if she gets off birth control pills, she's so fearful of pregnancy that she doesn't even want to have sex. So how do you handle that couple, either Sarah or Grace?
Yeah, thanks, Doug. I also say something, and then Sarah, you can add. Well, first of all, birth control. There are several methods that I'm guessing are going to be safe for her. So I would want to talk to her about like what her concerns are, and obviously look at her medical history. As Sarah showed, there are some risks that increase with age, and so the short answer is not an easy one, except to say that you just have to sit down with that particular person and go through their concerns and see what all of their medical risks are. But there's no birth control that is absolutely contraindicated just because of age. So there's no option that's off the table for this person. So you really do have to get into the nitty-gritty of what they do and don't want, and then and talk to them about it.
She doesn't mind the birth control pills. Can she just stay on? Because maybe she heard some of what Sarah said about the benefits of being on birth control pills. I'm not trying to talk myself out of a vasectomy, and probably most of us would just say to the guy, sure, come on in, I'll do your vasectomy. Unless he has a problem with the vasectomy, then someone could say, well, why did you do a vasectomy on someone whose partner is 50?
Yeah.
Is she does well with the birth control pills. She heard some good things about it, as Sarah said. Why not just continue her on birth control pills if she's a perfectly healthy woman otherwise, and with shared decision making, she doesn't necessarily have a problem with that?
She absolutely could continue using the birth control pills then. So
A-
I'll let Sarah see if she has
And
anything
how
to
would
add.
we know when she no longer needs them?
So the if someone doesn't have any other medical conditions, being over age 40, using estrogen containing methods, that's the MEC category 2, meaning like think about it, but in general, it's considered safe. And our rule of thumb, given the age of menopause and risk of pregnancy, is if somebody likes a method and they're using it, but the method itself is causing regular cycles, meaning not able to determine whether menopause has happened or not. It's just you can continue the method till age 55 and
55.
then stop it.
Okay.
Yeah. I
Very
mean, you can
helpful.
stop it sooner, but that's sort of like, I mean, and then you can talk about transitioning to hormone replacement and that type of stuff if you're using it for that reasons. But that's sort of a general rule of thumb. The issue with people being older is often it's not just age. Like maybe she's older, but she also has high blood pressure or something like that, or she's also a smoker. And then that means you want to consider other things. I've also seen couples like this where she's not on birth control, but she's 50 and her periods are starting to get irregular. And the person's coming in for a vasectomy. And you're like, do you really need a vasectomy? Like the chances of your partner getting, and I've had people say, she is in such a panic every time she doesn't have, and the fact that she's not getting her period regularly, I mean, she's in a panic for, the 2 weeks to one until she bleeds a little bit. And even if it's just for a year of her not having to be in a panic and us being able to enjoy sex with each other, it's worth it for the risk of the vasectomy. And that's fair.
Okay, because you could say, well, even if the couple lives in a blue state and they have no qualms about having a termination in the exceedingly unlikely event that she does get pregnant, still she's so irregular that she can't tell if she's pregnant because, if she stops taking the birth control pills, she doesn't know whether her periods are stopping because she stopped the pills or because she got pregnant when she did stop them. So it can be, I guess you just have to bring it down to shared decision making and balanced risks, as you said. All right, very good. Well, thank you for answering that. I don't see any other questions in the chat. Thank you for wonderful talks. And if nobody else has any questions, we'll sign out. Thank you to our
Thanks,
speakers.
Jen.
We'll see you in early June, I think, is our next webinar. So we'll look forward to seeing everybody at that time.
It's going to be a really good webinar with an AUA presentation of the new vasectomy guidelines. So definitely tune in for the information about June.
First Saturday in June, I think, isn't it, Deidre?
It's the 6th. Yeah.
First Saturday in June. Okay, thanks everybody. Bye-bye.
Thank you,
Bye,
everyone.
Thank you.